going to cover a lot of things in the functional medicine. So it's more of an interaction and a workshop kind of things. So I will not teach you theory and all stuff. So today's objective is why functional medicine is important and why it is something we have to think and we have to talk about that. What is functional medicine that I will talk about, and then I will teach you simple tools that you can implement in your next day morning practice. After 2 hours, you're going to change your thinking, how you're going to interact with your patient, how you take a history. So we teach you about the important tools that you can understand what the functional medicine meant. So I will teach you 2 important tools that will find out the root cause of your chronic conditions, that timeline and matrix. Then we'll talk about the body function. So I will give you confidence that you look at the lab and then you can find out so many conditions. Even looking to your CBC, so we teach you entire CBC, how you can interpret the CBC. Even sometimes your doctor doesn't know how to interpret the CBC. You can find out so many things, and then we going to show you about what you can learn more in functional medicine. So let's start. Why functional medicine is important. I don't want to show you that we have a tsunami of chronic conditions, but I will give you some data. So from morning you are learning about diabetes and pre-diabetes. Let me show you what the current scenario of chronic condition in India. So let's just look at diabetes. We have a 11% of diabetes right now in India, and if we count out the pre-diabetes, that the 15.3% of patients that right now in India, they have some kind of sugar dysfunction. They have sugar, fasting blood sugar more than 100. And if I point out the hypertension, then as per study, 24% of Indian male, they having a high blood pressure. And if you encounter that data for female, then it's a 21% of female, they are having an hypertension. Just imagine, 2 major disease. We have entirely 50% of Indian population, they have disease. They have either sugar dysfunction or they have blood pressure. And this number are rising. By the way, this number is before COVID, and as we know, after COVID, every chronic condition is on rise. And I would like to give you data about thyroid. Third disease. If we incorporate third disease, thyroid, then you will surprise that 20% of population, they have abnormal thyroid functions. Either they have high TSH, maybe it's 5 or 6, or maybe they have some kind of subclinical hypothyroidism. So we're going to show you how you can interpret and how you can diagnose that subclinical hypothyroidism. But just imagine, look at the data. If you look at this audience, like we have more than 100 participants over there, I can guarantee and definitely say you that 15 females from this crowd have abnormal thyroid functions. If you look outside, then 50% of population, they are having some kind of sugar dysfunction. And what we are doing. So I will show you the case, and I will show you, and I will just make you understand what is our conventional thinking process. That what we are doing from last 20-30 years, that how we are looking at this disease, and what is our thinking process. So my end goal is I want you to change your thinking process, right? And as we all agree that what we are doing in conventional thinking or conventional medicine is not enough to reverse the disease. If what we are doing is right, then this disease should not be there. It should be in a lower number, but we are missing something, and that missing part will be taken care of functional medicine. Let's take a case. So everybody say hi to Tina. Hi, Tina. Yeah, so Tina is 100 kg, and we meet maybe you are meeting this kind of patients in your practice. And as you look, she has gained the weight over a period of time. She has a delayed menstrual cycle. She had not gained the menstrual cycle for more than 6 months. And now she's also having an acne, and she's also having we can say hair fall and some conditions. So when we look at these things, our conventional mind start thinking that this is a case of PCOS, right? And I jump diagnosed. We are happy that looking to the symptoms, we are diagnosed with PCOS, and then our conventional thinking start like this way. What is the conventional thinking process? Yes, we have a provisional diagnosis that this patient having an PCOS, what we'll do? Ultrasound. We do ultrasound and we can find out the polycystic ovary, and yes, we are confirmed that this patient having an PCOS, let's put the patient on oral contraceptive pills. And that is our linear thinking. We put a patient on oral contraceptive pills, and what happens? Patient will have a menstrual cycle. That is normal. So patient is fine, doctor is okay, like patient having a menstrual cycle, everything is okay, but that is not the end of story. Patient complain about the weight. Now we have thinking process. Like patient having overweight, let's start the patient having some kind of sugar dysfunction, and let's start the patient and put the patient on a metformin. And that's our next step. So metformin, yes, metformin will work, patient lose some weight, and that's the thinking process. What will happen? Few years later, what will happen? This patient will have infertility, and we have a treatment for that. IVF, right? And then what we do? Few years later, this patient will have diabetes. Again, metformin, anti-diabetes medicines. This is our linear thinking process, right? And then, what is our conventional thinking process in nutrition? This patient having an obesity more than 30 is obesity. What is our thinking? Our thinking is patient having a high calorie diet and patient having a low exercise. That's the calorie in and calorie out fundamental. That's what we are thinking. We advise the patient, stop eating some calories, start workout. Yes, patient will get the benefit. Patient will lose the weight. How many of patient can sustain a low calorie diet for rest of their life? Nobody. They will do maximum by 2 months if their willpower is strong, if you are strong enough to count in a counseling. What after that? They start again eating, because nobody can sustain a low calorie diet, because calorie is very important, food is important, and we have to maintain the calorie. And then you tired, your patient tired, and finally what you say? It's your hormones. That's our problem. Go to the gynecologist, fix your problem, and then you will have a weight loss. And then patient moves from one practitioner to other practitioner throughout the life. He start on oral contraceptive pills, and then patient having an side effects of all the medicines. We have seen many patients who are put on OC pills, and they start developing deep vein thrombosis. And this is what we are doing, and we are conventional medicine approach. See, I'm not against the conventional. Don't misinterpret. I'm against, and I'm in alternate science, and I'm denying everything over there. Conventional thinking and conventional science is very important. We are developed with the purpose. But when we look at the chronic condition, this process and thinking process is not enough. So guys, my first question to you, do you think that we need a different map to understand this chronic condition? We cannot think in a linear process. In a conventional medicine, when the patient having any acute condition, we are right. If patient having any kind of chest pain, we have to do ECG, and if patient having any kind of MI, then we have to treat it. If patient having an accident, then we have to go and we have to fix the bone. That's right, we are doing the right thing. But when it comes to the chronic conditions, we are missing something. We need a different map. So are you agree with me, or are you resolute with me that we need a different thinking, we need a different map to understand this chronic condition? If you agree with me, then raise your hand. Yes. 90% of participants, they agree with me, and they want to understand what could be the map and what could be the another thinking process that we have to learn. So before I can introduce functional medicine, I would like to share my own journey. This is me in 2013. I am having a pre-diabetes. I am having a subclinical hypothyroidism. I am fatigued. I have low energy. I diagnosed with IBS. And if you go to the multiple doctor again and again, what they will diagnose you? If you go one symptom again, like fatigue, and I don't think, and I have pain, and I cannot energy, I cannot function. If you do same complaint again and again to your friend, because my friends are doctors, they diagnose you as a depression. Same thing happened with me. I diagnosed in 13 depression, and that depression is mild to moderate, not a severe depression, but that was a turning point of my life. I sit and I thought, Is this me? Why I am doing depression? There is something wrong happening. But they cannot figure out. Because the map in conventional medicine, even I learned the conventional medicine 20 years back, the map I am carrying is not for these conditions. Obviously, somebody having a severe clinical depression, then we have to use antidepressant, right? So I'm not against that. But that is that turned me in a functional medicine to find out the root cause. So one important lesson everybody should get from this is, if you don't get the answer in the box, think out the box. And that the functional medicine is meant. Functional medicine is not the alternate science. It's basically operating system. It's basically thinking process where you find out the root cause. Where you find out what is happening, why I am having pre-diabetes, why my sugar is going up, why I am having my thyroid function is not properly optimized, why I am having a depression, what's happening in the neurotransmitter. Is I am deficient with SSRI? That's what the conventional medicine is telling me. And if I take a SSRI, do you know 1/3 of the patients who take a SSRI, they have a 3 times higher chance of suicide. Do you know these things? It is there. It's an antidepressant drug. Selective serotonin inhibitor, that's the SSRI. So I done my MBBS 20 years back in 2000. I done my MBBS. Then I was studying my MS in ophthalmology, and I was certified in a international ophthalmology certification. I'm a very good phacosurgeon, and everything was fine. My life is settled. I'm enjoying my medical practice. But as you said, I told you in 13-14 I started shifting in a functional medicine. So I graduated from IFM. There is a world-renowned institute that teaching a functional medicine around 30 years. So I am completely certified with an IFM. Then I also certified in functional medicine because that's my passion to learn more about functional medicine. So I done whatever the institute to find out in the internet or in the world, that I am certified in a functional medicine. As you see, my interest was in hypothyroidism. So I had done a conventional certification in thyroid. So I have knowledge of both the world, conventional and a functional medicine. That's where I entered into functional medicine. And from last 5 years, I'm doing a complete practice of functional medicine. And I treated more than 5,000 patients of all the chronic conditions. That's what's my technical background. Let's jump on understanding functional medicine. Before that, I would like to show you what functional medicine is not. So I want to be clear about these things. So functional medicine is not the emergency medicine. We are doing the best thing in a conventional medicine when somebody have any kind of acute conditions. We are doing great things. Like I tell you, myocardial infarctions or heart attack or stroke or accident, birth defect. And finally, if somebody don't want to go for functional medicine approach, and many of patients you can find out they are comfortable with their medicine, they don't want to change their lifestyle, nutrition, and the rest of stuff, they are not for functional medicine. So clear about it? Functional medicine is for chronic conditions, lifestyle disorder, and so many force other. So these are the conditions you can treat with the functional medicine, and hope everybody is getting this kind of patient in their practice, right? So I told you 3 most common diseases like thyroid, hypertension, and diabetes that you can incorporate in your practice. That is the main thing. Otherwise, you can work on a rest of all the chronic conditions. So any symptoms that is more than 3 to 6 months, that can be taken care by functional medicine. So one important fundamental that differentiate the acute medicine, what we are doing, and the conventional medicine. In acute medicine, our primary thinking process is we have to find out the one cause for one condition. Let's say if the patient having a fever, what we do? We do an investigation and we want to find out what is that bacteria, what is that virus, or what is the parasite that is creating a fever. Till we find out that one, we do investigate, we do trial. But that is our thinking process, that we want to find out that one particular cause for that one particular condition, and that's a good for any acute conditions like chest pain. You have to find out the cause, one cause, right? So that is acute medicine. But when we look at the chronic condition, it is not that. So chronic condition can be within multiple symptoms like in depression. We can find out vitamin D is low, maybe omega-3 is low, maybe they have a low thyroid function, maybe they have some other cause, and so on. Even with the one physiological problem like an inflammation, as you heard in the morning, that inflammation can lead to so many conditions at the time. Inflammation can lead to the cardiovascular disease, inflammation can leads to gastric disease or hormone dysfunction or brain functions. But everybody will not develop the same thing. Some patient will develop some condition, some patient will develop other condition, and so on, so on, so on. And that's why we have a confusion, because our conventional thinking is find out that one cause for everybody. And that is not going to happen in a real world, because we see many patients with cardiac disease, they might be having a vitamin D deficiency and something like that. So this is functional medicine is biology based approach. So let's say in a conventional medicine, we talk about the organs. So we have ophthalmologist, we have ENT surgeon, we have cardiologist, we have name the organ and we have doctor for that. So our approach is to look at the anatomy. We want to find out any kind of structural deformity and that, and we have an investigation for that. So conventional medicine is primarily based on anatomy. When we look at the functions of the body and when we look at the disease, or when we look at the dysfunction of the body, it is like that we have a dysfunction that starts developing before we have any kind of structural problem, and then we diagnose the disease. So when we diagnose the disease, it's already late. So we have to find out what the functions, what the physiology is abnormal in that particular patient, and then we can treat that physiology. We can correct that physiology before we have any kind of structural issue and structural problem is there. So we want to find out the root cause. And that's what functional medicine is meant, how we can find out the root cause of these patients. One important question that every patient, they walk into our clinic, they ask either consciously, majority of time they are asking subconsciously, but a simple question that we are missing to answer, or even we are missing to ask the question. And that change your terminology. When you look at the patient in a chronic conditions, it's an entirely different thing. So one question that everybody asks is how I develop the disease. After 10 years, how I reach to your clinic? That is the important question. And then we have to answer the question. If you can answer the question, then patient can take care of their health and they can be a driver of their health. And that important question, I will teach you how most chronic conditions develop in the real world. Let's see that. So everybody has some kind of genetic background. But as we know in science, our genes are not our destiny. So if you look at the science and epigenetics, then you can find out we can turn on the genetics, we can turn off the genetics. So yes, you are right, 20% of the disease process is played by the genetics, and that is the one part, but that is not the end of story. This genetics means encounter with some kind of trigger. Trigger may be a tuberculosis, trigger may be their viral infection, trigger may be their stress, trigger may be their divorce, trigger can be their marriage, or trigger can be their malnutrition, or trigger can be parasite infections. And then they have bad lifestyle choices. We can say a mediator. So understand these things. We have genetics. If everybody understands Hindi, then I would like to use that one. See, मान लीजिए कि हमारे पास एक कैंप फायर है, लकड़ी वहाँ पर पड़ी हुई है, जलेगी? नहीं जलेगी. हम क्या करेंगे? उस पर डालेंगे पेट्रोल, एक आग लगाएंगे. अगर हम कुछ भी नहीं करेंगे ना, तो अपने आप ही आग बुझ जाएगी. क्योंकि the wood that is not prepared for fire. पर मान लीजिए कि उसी पर हम घी डालते रहे, क्या होगा? Then the fire will be there in a wood. If you remove the trigger, if you remove the mediator, वो कम नहीं होगी. So that's the philosophy. So we have genetics, we encounter the trigger, If you don't do anything, it will go away. But we have some kind of mediator, and that's usually a bad lifestyle choice. Maybe we are lacking in nutrition, or we are in a wrong kind of nutrition, or we have stress, we don't do exercise, or we have some issue with our relationship. So they are root cause. So I want to, and then patient having one dysfunction. Maybe it's a thyroid they start with, maybe this is a pre-diabetes, maybe they are IBS, maybe they are some kind of pain, and then usually patient will have multiple dysfunctions. So if your patients come with you with a sugar abnormality, don't think that patient only have a sugar dysfunction. When they walk in your clinic, already they have multiple dysfunctions. Maybe the thyroid, you don't look at optimal range and you cannot find out the thyroid dysfunction, but they have multiple dysfunction. Maybe they have IBS or gut dysbiosis, or maybe they have depression or something like that. So this is where the most disease develop. Now you go back, and I would like to show you this tree. So if you can see this tree, you can see the root. Root is our modifiable lifestyle. It's a relationship, how you relate with your family, with your colleagues, and with your environment. Then there is another things like stress. Everybody know about the stress. Then we have a nutrition, diet and nutrition. Then how we move our body, and then finally that we can say we have sleep and relaxation. These are the root. And then this root, abnormality in this root, I told you that we can turn off the genes. So if you have bad things, you can turn on the genetics. Then you might encounter with a trigger and mediator, and then you have one dysfunction, and then you develop a symptoms. Right? So this is where the most disease or most chronic condition will develop in patient's life and in our life. So this is how the first question. Now let's understand the same case. So recall the Tina. She is 100 kg weight. So how we take a history in conventional medicine? We ask the question, what is your chief complaint? अरे बाबा, patient को 10 साल से problem है. How we can patient find out the 3 chief complaints in just in 5 minutes? So we have to change our wording. We have to change our narration. And we change the narration. I will teach you. But as you see, our way to take a conventional history is ask the chief complaint, ask a past history, like this patient having a past history, no significant past history, only she had met with a gynecologist. She has a family history of diabetes, and then she doesn't have any find out except obesity. We don't find out anything in examination. And then finally we are diagnosed with a PCOS. And then the thinking process is like that, what I told you. But when we look at the patient, we have to understand how the disease developed, how she entered in my clinic and my office in 27 years. So we have to find out that reason. So we have to find out the antecedent, trigger, and mediator. So we can tell the patient, this is where you walk in my clinic, and if you can change these things, then you can go back and you don't require me or any practitioner throughout your life. And that's the antecedent. Understand these things. Antecedent means they have a risk of developing chronic condition in the future. That's maybe our genetics, maybe the preconceptions, what is a mother status when we are in a womb, or maybe it's some kind of nutritional deficiency. So before your conception, whatever you are having, we consider that antecedent. And antecedent means they are making you risk of developing future disease, but they are not the destiny. And then this antecedent, and then we can say the acquired antecedent, maybe you have some kind of early preconception problem over there, and then trigger came. Trigger means some conditions, I also told you tuberculosis that leads to some symptoms. So that's the trigger. So we have to find out the trigger. We'll teach you everything, trigger, mediator, and this thing. So trigger are usually environmental trigger. Maybe it's a stress, maybe some kind of exposure to infection, or we can change the lifestyle, and we can mitigate the trigger. And then mediator, as I told you, it's usually a perpetuator. Maybe it's a excess of something or deficiency of something. You can see deficiency of good protein, deficiency of good fat, omega-3, maybe excess of stress, maybe excess of carbohydrate, something like that. And that we usually consider them as a lifestyle issue, right? So let's understand this same in our case. How, when I take a history and how I make a timeline, and that's the one tool that everybody should learn and everybody should incorporate this timeline in their practice. So let's see how I look at the Tina. So Tina came with a current concern. So we had changed the narration from the chief complaint to a current concern. That she had a current concern, and then she came with a family history of diabetes. Simple meaning of family history of diabetes is her genetics doesn't like sugar for energy. Are you getting me? We don't give too much weightage on a diagnosis. Just convert that in a simple words. Now she understood from at the age of 27, she now knows that my genes doesn't like sugar. That's what she has a family history, and then she is born with cesarean section. So what do you mean by CS section? It is documented in the research science that if somebody is born with cesarean section, they have a 3 times or 4 times higher risk of developing any kind of autoimmune condition or any kind of inflammatory condition, because our gut is sterile while we birth. We take a good microbiome from the birth canal of a mother, where we engulf the good bacteria and all the rest of stuff. So who colonize first in the gut is very important. So CS section, usually the gut bacteria that colonize from the doctor's hand gloves and the atmosphere. You can find out what are the bacteria there are in a OT table. So that engulfed by the baby, and that is a risk for developing future autoimmune condition. I am not saying that every CS child will develop these things, but this is our data, and this is a risk of developing disease conditions. So we can consider that CS and family history of diabetes as an antecedent. Now she had done a tonsillectomy at the age of 10. Many patients, they have a tonsillectomy, but what is important over here, before that she had given a multiple course of antibiotics. Already she has a poor gut microbiome. She had taken a multiple course of antibiotic, and because she has CS, her immune system is not properly developed, and that's why she has allergy. But we are given antibiotic for long. I am not against the antibiotic. Antibiotic is important for, and they are life-saving. But do you know that 50% of antibiotics they are used in clinical practice is not indicative? If you give the antibiotic for respiratory infection, you will treat that disease, infection, in just 1 week. Just 1 week. And if you don't give the antibiotic for viral infection, you take 7 long days. So every doctor who is going to prescribe antibiotic for upper respiratory infection, and by the way, antibiotic used in India is not for humans. Antibiotics are basically used for cattle. And do you know that India is the one top country who produce and who import the antibiotic all around the world? Now just imagine what is happening with gut microbiome. We learn about fiber from morning. But if a gut microbiome is not there, what you going to feed the fiber? The wrong bacteria is going to take that. So what is important? Fiber or good bacteria? Good bacteria is important. What we have to found over there, but we have to look at this one. This antibiotic. Problem with the antibiotic is when you take an antibiotic, what you will do? You destroy the good bacteria. 90% of bacteria are there in the stomach. We don't have a fungus. But when you take a multiple course of antibiotic, what will happen? You will have fungal overgrowth. You have candida, you have yeast, you have so many fungus are in the body. But our good bacteria will control that fungus. But if you take an antibiotic, what will happen? They start having an overgrowth. Right? You see many patients who don't drink, but they have fatty liver. They have cirrhosis. Why? From where they are getting alcohol? Fungus is primarily eat sugar and they produce alcohol. Alcohol is a byproduct of fungal fermentation of sugar. What will happen? This patient having a fungal overgrowth, so they have imbalance, and they have imbalance, then they have gut dysbiosis. You learn about the intestinal permeability, and that patient having an already high carb diet. So now, understood? Genes are there, they don't like sugar. Now fungus is there, who invite the sugar, and they have high carbohydrate diet. Perfect room for metabolic conditions. And then she started developing insulin resistance. And then, insulin resistance, they have high insulin. And then she started having a menstrual cycle. What is the root cause of PCOS? Anybody? It's insulin resistance, but if you look at deeper, that's a high insulin that is interfering the ovary, and that's increase that delay the conversion of testosterone to the estrogen, and that's why they don't have a menstrual cycle, and that's the reason. So high insulin is a root cause. In many patients, you can see fasting insulin level normal. Now you are a patient, you understood everything, patient having PCOS, insulin resistance, everything is there, but if you do a fasting insulin level, that the insulin level came normal, what you will do? How you can diagnose the insulin resistance? Okay, coming back to the case, she is having an acne, I will teach you, don't worry. Then she's patient having acne. Why the acne? We know all signs symptoms of PCOS, high testosterone, dash is 2, and then finally she is diagnosed with PCOS, and for each and every condition we have pill. But we all know we have side effects of pills if we take for longer time. Even steroid is good for short term. Even OCPs is good for short term. Even metformin is anti-aging, that's good for short term. But if you take a long term, then you are inviting other dysfunction. As we know, metformin reduces B12. So it's not going to absorb the B12, and that's where you can see the disease develop. So this is where how I take a timeline. This is very important. So now you understood how this patient entered as a PCOS. Now she knows what to do, right? So this is number one. Now I want all of you familiar with the timeline. So we have activity. We give you a simple case, another case. Then everybody has a timeline folder over there, and Dr. Karishma is going to give you timeline. So before that, why timeline is important? Why timeline is important? So when every patient walk in my clinic, there were 3 subconscious questions, and that determine the whole story. If you can answer subconsciously this question to your patient, like even we go to the doctor, subconsciously we have a question like, can I trust this practitioner or doctor or nutritionist? We ask subconsciously, we ask the question, right? Second question we ask that, is my doctor practitioner is committed? We don't look at the degree because degree is already out there. We don't ask for the knowledge. Because when we selected, we decided by looking at degree. That is not our subconscious question. That's a conscious question. And then final question: do this person is committed for me? So if you are a patient, then while interviewing the patient, if you pick up the phone, you lose the trust. If you spend 45 minutes with that patient, because the patient is worked with many clinicians, many doctors, and they come to you with the hope, if you give a 45-minute complete time to that patient, I guarantee you that patient is for rest of your life to you. Even if you don't treat, even you don't give any results. Right now I have a patient who go to the cardiologist, who go to the neurologist, and they come to me, hey doc, can I start this medicine?
Mind brainstorming, right? Because the first session we have actually learned how to take a functional timeline. We have a very short activity. I want you to create your own timelines, right? So you have a functional timeline folder in your kit, a page. Can you please take that out, and a pencil or a pen? A pen has been provided. Okay. When you're ready, please let me know. Okay, so I'm going to give a case summary. In that particular case summary, it will be in a paragraph form. But as we saw Tina's case, you will have to put it in a functional timeline. You write your probable diagnosis or anything that you are thinking about just on the side of according to the functional timeline. And as per the functional timeline, we have not had the test reports of this patient. We have not had any functional testings done. Sirf history se agar kuch pata lag sakta hai, and you can brainstorm that and understand it. So let us do that, okay? Okay. So this is a patient, Dr. Manish. So you have to start writing, right? Dr. Manish, he's 46 years of age, male patient. Came to us with current concerns of high blood pressure, low energy, and obesity. He has had blood pressure since 2019. So in the chronological order of the diseases that it will come, you just put it as per your interest. He has been complaining about fatigue since last 5 years, and he was also diagnosed with Hashimoto's hypothyroidism since 25 years. I'll wait for a moment to complete this. The same case as we had done on Tina, I want you to put it in a chronological order. In this, yes. And on the right side, just a very small space. When we finish the timeline, I'll give you a period of 2 to 3 minutes to write down your probable diagnosis as per the timeline. Okay? Yeah. Understood or not yet understood? I'll explain it again. Yeah. So 2019, for example, 2019 है, तो 2019 कहीं आ जाएगा on the timeline. 5 years हो गया, तो अभी 2023 से consider कर लो. कि 2023 से 2024 से 5 years कहाँ होगा? So this patient is of 2023, so consider 2023 as the date timeline, right? और उससे पीछे ही जाना है. Yes, reverse is what we go. So you have to put the dates accordingly, the years accordingly, not the dates. Okay? Understood? A thumbs up from everybody. Understood? Yeah, ठीक है, चलो. So he was diagnosed with Hashimoto's hypothyroidism since 25 years. He also started gaining weight from 15 years of age.
Is anybody done? You can just raise your hands or just show me a thumbs up. Just till the Hashimoto's, not the entire thing. Hashimoto's तक हो गया? Yes, done ना? ठीक है. He also got infected with COVID-19 in 2021. After 6 months, just write COVID-19 in 2021. After 6 months of COVID, he suffered with a myocardial infarction, that is cardiac arrest, for which he got a CABG done. That is blood analysis. That is the entire process. When inquiring about past history, he got a rheumatic fever at the age of 6 years when he was a child. So जब वो 6 साल का था, he had a rheumatic fever for which he took some treatment. And what did he take? He took a dose of penicillin for 4 years. Penicillin is an antibiotic. Previously to when azithromycin was not there, penicillin, tetracycline, these were the antibiotics. So penicillin सबसे पहले आया, right? So and then came the tetracycline. And after that, the pharmacological department basically thought that because these antibiotics were given through injections and not orally, right? And then they thought that something should be brought up orally, and then the discovery of the azithromycin and other drugs started to happen. So penicillin for a period of 4 years is what he has taken. Family history: hypertension, obesity, hypothyroid, diabetes mellitus, heart disorders, and autoimmune conditions. Autoimmunity is basically when there is an immune dysfunction. Your own immune system is attacking your own tissue cells. ऐसा नहीं होना चाहिए, right? This should not happen. If something is coming from outside and your immune system should be so active that it should be attacking those things. But when your immune system starts attacking your own bodily cells, we call those disorders as autoimmune conditions. For example, Hashimoto's, lupus, I'd also give Duchenne's muscle dystrophy. ये बहुत सारे ऐसे disorders हैं that fall in the same category. Done with the family history? Yeah. Food and nutrition. He has been a vegetarian since birth. He has cravings for sugary and fast foods since college. Nutrition and diet is very important. He was diagnosed with B12 deficiencies 10 years ago and has been taking injections for the same. 2023 से तो 2013 आ जाएगा, right? Stress and sleep, very important. We'll be discussing about functional matrix when we see the matrices of the body, how they are involved. अलग अलग matrix में functional medicine basically works. तो food and nutrition एक part है, the disease formats are different parts. Stress and sleep has a very important part. Stress, sleep and exercise, right? The stress levels increased during the COVID times in 2020 due to hospital work. Sleep also has been disturbed for 3 years. Now that sleep cycle is also disturbed because he is not able to, the entire cycle has been disrupted. So this is the timeline of the person. Once you're done, just let me know. A thumbs up. Yeah. But please, thumbs up, So now, as per this particular timeline, on the right side, just write down any probable diagnosis that comes to your mind. It could be anything. जो भी आप सोच रहे हैं. It could be a nutritional deficiency, it could be inflammation, anything that your mind is thinking on the basis of timeline. And as we had seen Tina's case, as Dr. Anish had mentioned, that insulin resistance hua and then the hormone came into picture. See the functional timeline. See the family history of hypertension. These are the antecedents: obesity, diabetes, thyroid. Whenever we are taking a timeline, after the timeline is taken, it is very important for us to make the patient understand, or your client understand, that what he has been through or she has been through in his or her own language, right? Telling the patient's story in their own language makes a huge difference. Somebody tells me that you're suffering from some kind of a condition, and then explain me that what this condition and how this condition has developed makes a huge impact, right? So this is like a story. Had a birth in 1977, went through a rheumatic fever, for which he has taken penicillin dosage for a period of 4 years, right? That's a very important event. 4 years of antibiotics. Imagine the disruption of gut microbiota that must have happened, right, during that period of time. And also, as she clearly mentioned, that first 5 years are very important. Breastfed, whether it was a cesarean section or not, right? Complications during the pregnancy. See the mediators that he was getting weight gain in adolescent age, emotional stress due to the weight, emotional stresses due to biological conditions like COVID and working in a COVID hospital. 1992 started gaining the weight. Now because the gut microbiota has been disrupted, certain other things like hormone dysfunctions, and these also come into picture, because gut is a very important. 80% of your immune system is at the level of your gut, right? Then one more hormone, Hashimoto's hypothyroid in 1998, 2013 B12 deficiency, 2013 B12 deficiency, and 2018 he developed into fatigue, one symptom after the other. And 2019 high blood pressure, and 2021 COVID positive, and he also developed myocardial infarction, right? And now he's at 46 years of age, and he's having current concerns as high blood pressure, low energy, and obesity. Now this particular timeline, so you have understood that how you have to jot down the timeline.
Everybody ready to put all information in a one single paper where you can find out the root cause? Okay, so let's understand how we can find out the root cause. So how we can find out the root cause? So all the information, every participants we are talking about, that the antibiotic or 5 years are important, or gut microbiota is important, but how we can find out in the root cause, and how we can put all the information in a single paper that you can find and you can tell the patient the story, that they can understand the root cause. So this is functional medicine matrix. So if you can see, a lot of things are there, but I will make you simplify, don't overwhelm. So I will make you understand why the Tina or why the Dr. Manish had developed a myocardial infarction. So how we can put all, and we can find out the root cause. You can see on the left side, you can see antecedent, trigger and mediator. Now everybody is familiar with the antecedent, trigger and mediator. That's the left side panel. And then you can see on a bottom, we have a modifiable lifestyle factors. It may be a sleep, it may be nutrition, it may be your exercise, stress, and relationship. So this is a matrix, and you can see on lower bottom. In the center, what we talk about physiology, what we talk about the function. There are 7 important functions in the body, and they are very important, and we have to understand that. I will teach you all the functions in detail so you can be familiar with all these functions. And then finally we have to put all the information in this matrix so you can find out the root cause. right? And let's understand the three important concepts of plague that personalize: ATM, antecedent, trigger, and mediator, lifestyle factors, and then biological process that we talk about the physiology. And that's three important legs of a stool, and health is important, how we can find out the root cause. The 7 nodes or 7 physiology or 7 major functions of the body, that each and every function I will explain you in detail. So the first important function you heard in the morning, that disease appear in the gut, and if you want to heal the disease, then we have to start walking from the gut. So assimilation means we take something from outside, maybe it's a food, maybe it's air, we process them, we take something from there and we take something out, maybe it's a carbon dioxide or maybe it's a stool that we are throwing out of the body, and that's the assimilation functions. So you can understand the respiratory functions and the gastric function or gut function, they are on a assimilation side. And you learn about lot of breath that we take in a day-to-day out. Skin is also our assimilation organ. I will tell you data. It is research that when women, you all guys, out of your home in the morning, you are taking a 230 average chemical in your body from skin. Can you believe it? Maybe it's your lipstick, maybe it's your cream, maybe something you are applying on your skin, maybe your clothes, maybe your deodorant. That's the assimilation organ. We have to think differently. We have to think that what the assimilation function, dysfunction, we don't always talk about the gut is the only problem. We have to think about the respiratory system. We are taking so many chemicals from our breath. Even apart from smoking, we are breathing so many toxins like mold, or maybe it's some kind of chemicals we are breathing. But that's the assimilation function, the very important functions. If your assimilation function is not proper, you will not absorb nutrient, and your difficulty in even creating your health. Another function is detox function. As you all know about detoxification, you have detox diet and detox supplements and detox cream and detox so many things. But we know that it's not just a detox. We all are exposed to a chemical from day one to day and day out. So if you look at the science, it's not the toxic load only that is creating a problem. It's a toxic load plus the ability of our own biology to get rid of the toxins that leads to the effective toxic load in the body. So if we tell the patient that you are toxic load, remove these things, but as a doctor, as a practitioner, we have to work on that biology. We have to find out why my patient is not detoxifying. Is there issue with the nutrition? Is there issue with their genetics? Or is there issue with any kind of gut microbiota or something else? That's the detoxification and elimination. So we have 2 major organs that are responsible for detoxification. One is liver, all you know. Another is kidney. So what is the difference between kidney and liver? Anybody? So we have 2 kinds of toxins in the world. One is water soluble. Another is fat soluble. Like we have vitamins, A, D, K. They are fat soluble. And the rest of vitamin C and vitamin B, they are the water soluble. So same, we have toxins, they are water soluble. And we have toxins, they are fat soluble. We don't have any issue with the water soluble toxins. You drink the toxins, the kidney is there, remove the toxins after 2 or 3 hours. So we don't have any issue with the water soluble toxins. The only problem we have is with fat soluble toxins. So everybody have non-stick and they in your house. How many don't have a non-stick in their house? 2, 3 people. So 98% of the population right now here, they have a non-stick in there, the Teflon coating. And do you know that what is the half-life of Teflon? So if you eat a Teflon, how much time that body need to eliminate that Teflon, and that's half-life. We calculate in the pharmacology. Like you take a paracetamol, then half-life of paracetamol is 6 hours, means your 250 milligram of paracetamol will be eliminated in the body within a 6 hours. That is a half-life. So what is the half-life of Teflon? Anybody? It's 8 years. Now, before you cook anything in a non-stick, think about this. And most of Teflon that if you use of 1 year, the coating will be not there. Where is the coating? Half of the coating is gone in a wash, and the rest of Teflon is in your body. Your body and your cell can get rid of that Teflon. It's just a simple example that you are using in your day-to-day life. There are so many toxins we are eating, breathing, and we don't aware about these things. Maybe some information that right now I am giving to you may be overwhelming, maybe it's creating a pain, but I want everybody to take this pain and take this movement forward to tell the patient and tell the world, we need to change something. Why we have a disease? Because we are exposed to toxins and we have nutritional deficiency. We have a world of nutritional deficiency. And for the last 30 years, we are exposed to one more chemical every day. Everybody will not have the disease. Because if somebody have a detox liver healthy, they can eliminate the toxins. But if somebody doesn't have a liver, they have some kind of snaps over there, they cannot, if they have nutritional deficiency, they cannot take. So the entire process of phase 1, phase 2 detoxification, so we have to correct and we have to find out where my patient have a defect, and we have to correct the defect in a detoxification. Another function we can say, everybody know about the hormones, like everybody know about the HPA axis, hypothalamus pituitary axis, that we all talk about the stress and we don't have to take a stress. How many of you that think if we tell the patient then don't take a stress, and they will not take a stress? They take a stress of not taking a stress. You are right. So don't tell yourself then don't take a stress. Don't tell your patient then don't take a stress. Teach patient how to balance the stress. That is important. If you know the physiology, then it will start from your hypothalamus, that is your H. Then it's a pituitary gland, that is the hormones. Then your adrenal gland that responds to a stress. There are many stages of stress that come. First is, we can say stage 1, that is arousal, where patient is active and this patient is very much enjoying that stress because they have high cortisol and they like that. But high cortisol will not stay longer, maybe 6 months, 1 year. And then they go on a stage 2, that they cut down their cortisol, they cut down their DHEA, and then stage 2. And when patient come to you, like I did 7 years back, fatigue, I don't have morning energy, I wake up in the morning, but I don't like to work in the morning, I don't enjoy my morning, that's your patient with an adrenal fatigue. They have low cortisol. So that's the HPA axis. You will just think about that patient having some issue with their chronic stress. And chronic stress is a problem that you can diagnose and you can treat. Even you can diagnose with the symptoms, or if you are lab available, then we can teach you how you can find out and how you can diagnose the HPA dysfunction. More than HPA dysfunction, that's actually a limbic system that is having a problem. So limbic system is entire new concept, and if the patient having a chronic stress, they change their biology. The new science is there that's called a neuroplasticity, and that says you can change your brain. Before 25 years, when I was learning my MBBS, I'm learning in neurology, it was said that you cannot change your brain. If you're diseased, your brain is like this one, and neural tissue you cannot change. You cannot regenerate the neural tissue, and science is proven wrong. We have a research in neuroplasticity. You can change your brain. You can create a new pathway. Yes, no, that is not the programming, but NLP is one of part of managing the stress and something like that. But here my concept is showing you neuroplasticity. The important learning is we can change brain, right? There are many ways we can do it. One of the ways is we can do a psychology or counseling, but NLP is one of the way. But here the concept is patient might be having some issue with the hormones. So we have a hormonal dysfunction over there. And then we have a transport. We transport the molecule from the brain to adrenal gland, from the leg. We are transporting so many molecules, and that's the transport functions. Collectively, we call as CVS or cardiovascular system, but that's just a part of transport system. We transport insulin, we transport all the hormone within protein that we call as sex binding globulin, or we can say hormone binding globulins or thyroid binding globulins. So somebody having a protein deficiency, what will happen? They don't have that protein that can transfer the hormone from the origin to a target tissue, and they have difficulties. So we have all functions we call it transport functions, from the cardiovascular disease to hormones. We need that functions, and that is called cardiovascular functions, right? And then we have mitochondrial functions. How many of you know mitochondria? Everybody know, right? Everybody knows. So I will give you some information. Do you know how many mitochondria we have in the cell? How many mitochondria do we have in our cell? We have almost 800 mitochondria in each and every cell. And why your heart is pumping from morning to evening without rest? Because they have 5,000 mitochondria in single cardiac cell. If the patient lost their 30% of mitochondria or 50% of mitochondria, what will happen? Heart cannot function. That's the root of LV dysfunction or cardiovascular dysfunction or CCF, you can say. They have a mitochondrial dysfunction. So mitochondria is very important, and if you weight of mitochondria, so if I drain out all your mitochondria and if I weight, then the weight of that mitochondria is 10%. So if you are 60 kg weight, then 6 kg of weight is because of mitochondria. Now tell me, eyes is important or mitochondria is important? If you can remove one eye, patient can live his life. There is no issue. If you take out the entire lung, then patient have a normal lung function throughout his life. If you remove the half liver, everything is normal. But if you take out 30% of mitochondria, you cannot function. 3 important symptoms of mitochondrial dysfunction. If your patient having an drain, fatigue, and brain, everybody. Drain, fatigue, and brain. If your patient has some issue of depression, anxiety, if your patient complains about low energy, fibromyalgia, pain, so it's a drain, pain, and brain. Chronic pain. They lost their 30-40% mitochondria. So again, pain, drain, and brain. Maybe it's Parkinson's, maybe it's anxiety, maybe it's neurodegenerative conditions, maybe it's something else. But you find out these symptoms, you consider that patient need to be having a mitochondria, and you jump on working on mitochondria. And your thinking will be what the nutrition, what the food I can give to this patient, they can increase mitochondrial dysfunction. What the nutrition I can give to the patient, they can have a mitochondrial functions. What the exercise or what the prescription I can give you, that can increase mitochondrial dysfunction. So we have to increase the number of mitochondria. Same way we have to work number of ATP. Do you know? Everybody know that our mitochondria produce ATP, right? How cells store ATP? It's a magnesium ATP. Body produces the ATP. It stores the energy in a form of magnesium. It binds to the magnesium, and then it can store the ATP. Now just imagine the data. 99% of the population in this room have magnesium deficiency. I guarantee you. But we are looking at the wrong test. We are looking at serum magnesium. That is not the test for magnesium deficiency, because only 1% of magnesium is there in a serum. The rest of magnesium is intracellular. 49% of magnesium there lies in the cell. The rest of magnesium is in the bone. So if you look at the serum magnesium, then you are doing it wrong. You have to do the RBC magnesium, but we don't have a RBC magnesium right now in India, so we have to rely on a symptoms and statistics. Like vitamin D, 90% of population they have vitamin D deficiency. So if you correct the magnesium, you're also correcting the energy. You're working on mitochondria, right? And so many things are there for mitochondria. But just I'm making you aware about the major functions. The major function is there, mitochondria. If your mitochondria healthy, you are not aging, because each and every cell need energy to work. Each and every cell need energy to functions. And finally, we have another node that we call structural integrity. So every structure should be there, and conventional medicine is only focusing on these functions. The rest of function is ignored, and that's what we have to learn. So maybe patient having some kind of leaky gut, or patient might be having some kind of issue with the thyroid or inflammation in thyroid that destructs the cells and the tissues over there, and that is the structural integrity. Very important function is immune system. Everybody knows that immune system is for defense, but do you know that immune system is main job is not to defense? Where is our Indian Army? What they are doing? They are doing just the surveillance. They are on a sleeping mode. Our defense system should be in sleeping mode all the time. We have two immune system. We can say innate immune system and acquired immune system. So immune system is in charge. So any pathogen enter in the body, we find out them. We don't require any prior exposure. We destroy that one. We don't tell the commando that there is a problem. When you last time heard that we require a commando? I think in the Mumbai attack. That's our acquired immune system. They should be sleeping. We don't need them. We only need them for some acute problem. They should come, clear the mess, and then go sleeping. That's the functions of acquired immune system. We don't need that. Right? But what we are doing right now, what our immune system is doing right now, with most of patients, you heard about the chronic inflammation. What is chronic inflammation? Chronic inflammation is commando. They don't know what to fire and what to save, because our innate immune system is programmed since many years and years that they know that this is our cell and this is not our cell. We only have to kill the pathogens, but our acquired immune system don't know this one. So they will find out the trigger, and they will find out random firing, and they will kill whatever come in a picture. That's the chronic inflammation. So we have antibodies, we have T cells and B cells. Your B cell is active, then your B cell is creating antibodies. Antibody target your tissues, and then your T cells, they come in a picture, and they will create a chronic inflammation in your thyroid, and then the way you have Hashimoto hypothyroidism. So everybody know Hashimoto hypothyroidism, right? What is the root cause of Hashimoto hypothyroidism? It's the immune system, right? So it's the root cause is immune system. But the question is again, ask the question: why the immune system is creating stuff? The acquired immune system is too much active. We have to balance the T1 and T2. Let's make the immune system T1, T lymphocyte and B lymphocyte go and sleeping. Let the immune system, let the dendritic cell, let the neutrophil come in active, kill all this what the mess is there at our border. As we said, the Indian Army is the border. You know, where is our human border? We have immune functions. We know the defense and repair. So we have our border at gut. You are right. So our major border. One primary mistake we are doing when we look at the gut. Let's say, if you eat some food. Food is in your intestine, right? So my question is, do this food is in the body? Do this food, whatever the food sandwich where you are taken in the morning, do this sandwich is in your body? No. Just imagine I am putting a sandwich in my mouth. Technically, the sandwich is not in my body, it's in the lumen. So when we throw the digestive enzyme, even the amylase from the saliva, and we have all entire system of enzymes, we throw the enzyme, we break down this property, and that particle cross the mucous membrane from the mouth, from the gut, and then this particle go in the body. So lumen is not the human, technically not the human part, it's actually external wall. You can consider as a border. So our gut lining is actually a border where we need a lot of defense. So our majority of immune system is at the gut, and that is we call a gut associated lymphoid tissue, and that's called the defense and repair. So main job of immune system is to repair. So we have trauma every day. We regenerate each and every organ daily, including your nervous system. Technically, we are making a skin upper layer in 24 hours. So you wake up in the morning, you are entirely new coating. Who do this job? Immune system, right? So immune system main job is to defend. We don't need repair. We don't need defense. And then we have a lot of inflammatory. So if you look at chronic condition, then the primary cause of chronic condition is, as said you, that's because we are encountered with many toxins and we don't have that nutrition to deal with that toxins, and we start having a dysfunction in a system. And that's the metric. So again, say hi to Tina. We are coming back to the Tina case, so you can understand the process, timeline. Then now we have to tell the Tina that what is the root cause. So we tell the Tina, there's a story that Tina, see, you have a genetics for your diabetes, and I said the simple meaning of diabetes is your genes doesn't like sugar. So if you feed sugar to your genetics and sugar meet to your genetics, you will eventually develop some kind of insulin resistance, or maybe you are prone for developing diabetes. Cesarean section, we already talked about that you are risk of developing any inflammatory condition because your gut microbiome is poor, and because you have taken a lot of antibiotic, your gut microbiome further disrupt, and the inflammatory process is already started before you diagnose with PCOS. And look at your lifestyle. You are not moving, you are taking a lot of high carbohydrate diet. By the way, carbs means not a fiber, it's a simple carbohydrate, and a starch that she is high. She is having a multiple nutritional deficiencies. So if the patient walk in a clinic, you look at the report and you find out low vitamin D, and you say the patient that you have a vitamin D deficiency, that is not correct. Because we check only vitamin D, we can say vitamin D deficiency, but somebody having a vitamin D deficiency, all the fat soluble vitamin, they are low. They have multiple nutrition deficiencies. So don't look at just 10 vitamin D deficiency in isolation. If you do the testing, you find out the B12 low, that means patient is having a multiple deficiencies over there. And you all agree that patient is having a lot of nutritional deficiency over there. Same thing, this patient having a lot of mediators. Now you can understand? Nutrition deficiency, high carbohydrates, stress, and you can look at all the root. She is disturbed in her sleep, she is not moving, she has a problem with her mother, she is having a high health stress, and she is taking all junk food and high carbohydrate diet. So this is where, and you can look at the matrix, she has a problem with an, as we said, that she has a problem with an communication node. So now if you look at this case completely, then you can find out this patient having some kind of hormone issue because she has PCOS. So his testosterone level is high, his estrogen level is high, right? So this is where you can see high insulin is there. So she has some problem in a communication node, and then you understood about the timeline that she has some issue with an defense and repair node. She's inflammation. But from where the inflammation is coming? It's coming from the gut. Why? Because she has an imbalance in a gut microbiome. We call that a dysbiosis. Dysbiosis means imbalance in a gut microbiome. The good bacteria is low, and then she has a fungal growth or something like that. So you can see that two major functions, they are altered. Even you can incorporate the third function gut, but I will keep the gut function out. But two functions, you can see that this patient is having an defense and repair, that is a problem, and then she has a problem with an communication node. Now you can tell the patient story that this is the antecedent, this is a trigger, and this is a mediator, and then you develop your inflammation in the gut because of dysbiosis, and because of that dysbiosis, you might be transferring your inflammatory molecule from your gut to the body, and then you have inflammation, and because of inflammation, you develop the insulin resistance, and then you have high insulin, then high insulin is disturbing your ovary, and then you don't menstruate, and you have high testosterone, and that's why you develop the acne, hirsutism, and you don't have menstrual cycle over there. Does it make sense? Now tell me, if you tell this story to your patient, do patient have any complaint that he is not following your advice? Patient become non-compliant. Now you empower the patient. Now patient know where I need to work. Make a simple three point. Don't do anything. Just show this patient and tell the patient that we have to modify your lifestyle factor. We have to modify your immune system. We have to modify our hormones. If we change these things, do patient reverse the PCOS or insulin resistance? Do this patient develop diabetes? Do this patient need an infertility treatment? I am treating many patients with PCOS. We are giving a simple lifestyle. We are teaching them, do this thing, do this thing, do this thing. They will change. We will change the hormones within 2 months. From last morning, everybody talking about high protein and fiber. Nobody talk about the omega-3. How many of you in this lecture know that omega-3 is important? Or omega-3 is not important, in fact? Everybody know omega-3 is important? I am asking you a question. From last 30 years, what the omega-3 you are eating? What is your requirement of vitamin D with omega-3 that you are eating? No. You know that you are deficient in omega-3. Omega-3 is important for so many functions. Nobody talk about the good fat. Your cell cannot sustain on a protein. We cannot use protein for energy. It's our last step for body. In your body go in a catabolism, then you break down the muscle, but that is the last sorts of you can use energy. Protein is not a good choice for energy, but fatty acids are the good choice. So we can shift the patient's metabolism from exactly. That's what we want to do it. And then we have to take care of rest of things, like we have to correct the diet, nutrition, we have to correct the stress, and we have to teach them. We can do so many things over there, and then we can find out that every time when patient come in a follow-up, create the matrix. Show the patient, this is the matrix 6 months back, this is the matrix you came after 6 months. See how you change. Now patient have a clear vision that we have to focus. I corrected my exercise, I am doing good that. So now I have to work on this 3 simple steps. With my experience, patient can only follow 3 simple things. Don't give a 4th one. Even in nutrition, even in supplements. And then call the patient after follow once they correct this one. So this is how we are diagnose the root cause, and hope everybody understood the root cause. We are given you a complete matrix, so you can go home and you can find out, and next day morning you can find out some, try to learn this. In a conventional medicine, we always talk about, conventional medicine is science-based, we talk about a lot of evidence-based science, but as per my experience, because I have experience with both the world, like functional medicine and conventional medicine, finally I arise at simple statement, medicine is not actually a science. It's an art. Because science is a part, but we can say 70% is art and 30% we can say it's a medicine. But basically what I learned from my whole conventional thing, that science-based approach, we need evidence, we need that and that and that. And if you look at the evidence, then 50% of studies that you see in a literature, they are actually wrong. This is not me saying, this is the British Journal article published in 2015 that says that 50% of studies that you see in a medicine, they are actually wrong. They don't have any evidence. Now what study you are looking at, you have to think. Right? So don't just look at the studies and all the research, be yourself, be a scientist. So as for me, the the art of healing the patient, or to do a medicine that you need to be learning. And last lecture, are you interested to learn simple cases that you can interpret CBC tomorrow morning? If you have energy like me, then please raise your hand. So almost we have 70% participants, they are interested in learning the biochemistry and they want to learn about the CBC. So I will go through this lecture very quickly, and then we have interaction like optimal range and conventional range. So important fundamental when you look at the lab is optimal versus standard range. So you look at the conventional lab, they only says you the standard range, and that is very out of range, out of concern, because standard range you cannot find out the dysfunction. So we have to look at the optimal range. So I am going to give you 6 simple cases, and I want everybody to participate in that case. Let's see how you and what you know about CBCs. Let me show you this case. Okay, case number 1. She is 28-year-old and she has CBC. Like you can see, she has hemoglobin level is low, and then we have an entire CBC panel of MCV, MCHC, and you can see that. Now, yes, we know that this patient having an anemia, but now we want to find out the cause, right? So anybody have idea what could be the cause of anemia and how we can diagnose with this parameter that this patient having an dysfunctions, and what kind of diagnosis you want to make? Lack of intrinsic factor. Yes, we have seen TIBC that is low. Yes, some of you are right. This patient having an iron deficiency anemia, and you can see how we can interpret. Just look at this report. You can see hemoglobin. So when you look at the conventional lab, you cannot find out really picture that you can diagnose quickly. But if you look at this one, then you can see hemoglobin level is low. That MCV, MCSC, they are also on lower side. So you can quickly diagnose that this patient having an iron deficiency anemia, because MCH and MCSC both are low, and you can see that their PCV is normal, beta RBCs are normal, but they have a deficiency of iron. It's a microcytic anemia that you can look at this picture and you can find it out. Okay, so it's a iron deficiency anemia. Okay, now we are on the case, and you can see the markers of iron. Like we can see serum iron level is low. Ferritin level, always check ferritin levels. If you want to run a one test, then don't run a serum iron. Run a ferritin level. You can find out that is very low. Even sometimes we have seen the patient having a normal serum iron level, but they have a low ferritin level, and your target is optimal. Make it 50. So if somebody having a hair fall, what you will do? You do ferritin. You do protein, because protein, thyroid, and iron, they are important for your hair, and many of patients having an hair fall in hypothyroidism. So this is iron deficiency anemia. You can see TIBC and everything is raised, but particularly look at the ferritin level, and your goal is to make ferritin level more than 50. Keep it over there. And then we have another case number 2. Now you can see again hemoglobin level is 12.7. That's a very good hemoglobin. It's not bad, right? Good hemoglobin. What is the optimal range of hemoglobin if you want to be energetic, if you want to be anti-aging? 13.5 for female. For male, it should be more than 14.5. So you look at the hemoglobin level is low, you jump on diagnosis that patient having a mild anemia. But you can see MCV, MCSC, they are slightly on a higher side. So what is the cause? Okay, one of participants is right. This patient having an B12 deficiency, and that is called megaloblastic anemia. And you can see from this report the RBC is normal, hemoglobin is low, but you can see really here that MCV and MCSC, they are on a higher side. So this is a megaloblastic anemia, and megaloblastic anemia is B12. If your patient is having pre-diabetes, diabetes, PCOS, and they are taking a metformin, you see this kind of picture when they have a normal iron. Right? So you can differentiate between iron deficiency and B12 deficiency, just look at the MCV, MCSE and rest of marker. Just look at here and you can diagnose these things. Now we have another case, and I want everybody, so you learn about the iron deficiency, you learn about the B12 deficiency. Now third case, and you can see the B12 level is very low, and folic acid may be in low optimal, and this is our third case. Now you can see hemoglobin level is 11.7, but all the markers PCV, MCV, MCSC, MCHC, every marker is in an optimal range. Now tell me, what is your interference? What is, how you interpret this case? So whoever answer this question will be appreciated. Anybody have a clue? She is right. This patient having both the deficiency. When you have iron deficiency and you have B12 folate deficiency, your size of RBC and MCFC are normal. So this patient having both the deficiency, B12 deficiency, they have folate deficiency, and they have a iron deficiency. So when you look at the low hemoglobin and all the markers, they are normal, you consider them both the deficiency, and you can see when you repeat, when you see this kind of picture, you can see slightly on higher side but almost in optimal range, and you can see iron level is slightly on lower side, ferritin level is 26 point, but you can see TIBC, so you can see a mild iron deficiency and they have a B12 deficiency. So somebody having mild to moderate B12 deficiency, somebody having a mild to moderate iron deficiency, you can see this kind of picture where hemoglobin level is low, but you can see their level of MC is normal. Now we have 3 more cases to go where we interpret the WBC. So guys, are you ready for understanding WBC? Because your doctor will only look at the total WBC count. If it is more than 11,000, they will prescribe you antibiotic, but this kind of patient you will not get in your clinic. You will receive the patient, there are some kind of chronic conditions, and if you look at the WBC, then you can see WBC is completely normal, but you can see neutrophil count is 82%. They have high neutrophil count, but look at the WBC count, normal. So your doctor will not do anything. They will send you home back. And then you can see lymphocyte count is 28 and 6 and everything is fine. So we interpret that this patient having a chronic bacterial infection. Maybe that infection in the mouth, maybe that's infection in a urinary tract, maybe that infection in a gut. Most probably we are seeing the patient, they have some kind of dysbiosis in a bacteria, and they will develop this kind of picture where the neutrophil count is slightly on the higher side. But you consider that neutrophil count, then we increase, we consider them as a chronic bacterial infection. You repeat the testing and again you see the same picture, again the same picture, then patient need to get rid of that chronic infections. So that's the case 4. And you can see neutrophil count is 82, and just from this report you can interpret and you can visually see that where we should look at the disease. Case number 5, you can see WBC count is again normal, but the lymphocyte count is increased. So normally you see lymphocyte count around 30, 35, that's a good amount. And I said you to immune system, innate immune system, acquired immune system. What is our acquired immune system? It's a lymphocyte, T cells, B cells. So your T and B cell is increased. Now you understood? Or commando are active, right? What kind of infections? What kind of infection this patient might be having? Yes, you are partly right. So viral infection, usually your lymphocyte come in a picture, and your chronic viral infection, maybe it's Epstein-Barr virus, maybe it's cytomegalovirus, maybe it's autoimmune conditions. So if you look at any patient of Hashimoto hypothyroidism and you see that patient's lymphocyte count is high, consider that patient is having a relapse. Right? And we want to keep our patient on a remission. Remission means that lymphocyte count should be less than 30. We don't need an T cells and B cells to be active. So that's, so maybe you are right. Right now we are not talking about the acute conditions and cancer only. Yes. But lymphocyte is primarily responsible for viral infections. Maybe it's even if you look at the cancer, then maybe the viral etiology will be there. Maybe again the cancer, the lymphocyte will come in the picture and we want to remove the mass. So cancer is entirely, we can talk about hours and hours for cancer. But right now my purpose here is to make you understand that this is acquired immune system that is active, and usually acquired immune system is active in autoimmune conditions, and the second most common cause is viral infections. Now, I know everybody is tired of a lot of information and your brain is exhausted, but the final case, that's very interesting case.